huge range of issues that can be treated with stem cells, and I'm going to try to touch on as many of those tonight as possible. Okay, just a little bit about me. I've been around here for a while, sports medicine, working with a lot of the local collegiate and professional teams. I'm a fellow of the American Academy and a diplomat of the American Board of Family Medicine. I'd like to thank Shannon O'Kelly and the whole team and all his clinics at IRG Physical Therapy for putting this on and inviting me to do this. We've done a few of them in the past, and they've always worked out really well. Okay, so we're going to talk about there you go. All right, we're back. We're going to so some of the conditions that we treat. I'll start out. We do more knees pretty much than any other joint, and the things that we deal with in knees are, number one, osteoarthritis, which is wear and tear arthritis of the joint. Osteochondral defects, which are like little holes or craters that develop within the cartilage and go down to the bone. Meniscus tears, partial ACL and PCL tears. We can't treat complete tears because we just can't bring the ends back together. That requires a surgical procedure. Chondromalacia, which is pretty much damage to the Teflon covering, but not down to the bone. And then inflammation, which is synovitis, and tendonitis, or sometimes even partial tears of the patellar tendon, which is the tendon from the bottom part of the kneecap that extends down to the lower bone or the tibia. We treat osteoarthritis in pretty much ankles, knees, hips, wrists, elbows, and shoulders. I also do sacroiliac joints as well. Some of the other things that we treat outside of knees, we do a lot of rotator cuff tears and then labrum tears. Labrum is like when people talk about meniscus tears in their knees, well, the labrum in the shoulder and the labrum in the hip is similar to what a meniscus is in the knee. And we treat those and have great results with those as well. We also treat Achilles tendon injuries and numerous muscle and tendon injuries. Oops. So we're not progressing on with the, click on the screen again. Okay, here we go. So what is regenerative medicine? It's the field of study that utilizes stem cells to heal and regenerate damaged tissue. It's the use of autologous, meaning from your own body, adult mesenchymal stem cells to regenerate bone, cartilage, muscle, and tendon. The cells that we isolate from bone marrow and from fat are called adult mesenchymal stem cells. And we only want that particular cell because they can only grow up to be muscle, tendon, cartilage, and bone. We don't want all these other, what we call pluripotent cells. A stem cell itself is a unspecialized cell that has the ability to renew themselves and to transform into different cell types within the body. I've got a little short video here that's just like a cartoon that I put together that kind of tells you what stem cell therapy is. So this lasts, I think, about 4 minutes.
What is stem cell therapy? Stem cell therapy is an injection treatment designed to heal injuries and reduce pain. It is used for arthritis, What is stem cell therapy? Stem cell therapy is an injection treatment designed to heal injuries and reduce pain. It is used for arthritis and injuries to ligaments, tendons, muscles, cartilage, and bone. First, let's look at the difference between human embryonic stem cells and adult stem cells. The embryonic stem cells are pluripotent, meaning that they can become of any of the more than 200 known differentiated cell types of the human body. On the other hand, adult stem cells are multipotent, meaning that they can develop into more than one cell type, but are more limited and controlled, and thus safer than pluripotent cells. We perform the adult stem cell treatment. What is the role of these stem cells? To understand this better, let's look at this example. Your house is exposed to different elements, such as wind, fire, rain, sun, and time. All cause damage to the structure. To keep your house in order and repair any damage, you need different professionals like firefighters, construction workers, insurance agents, and a contractor to supervise and direct the project. This is no different than your personal life. You need a dentist, lawyer, financial advisor, doctors, insurance agent, and a barber, along with other professionals. So, both your house and your life require different professionals and specialists to keep them working well. And your body needs stem cells. Now, let's dive deeper and see what happens to your joints. In a normal healthy joint, you have plenty of stem cells. These cells are not only capable of doing maintenance and repairs, they also know when and where these repairs are needed. The stem cells work as a contractor that, in addition to giving instruction for repairs and maintenance, can transform into specialized cells to do whatever is needed to fix any problem. When you have enough of these stem cells, there's a balance between damage and repair, and you have no pain and no injuries. Think about when you were 18 years old. You were able to run, jump, and do the same the next day without pain. The only problem is that with time, the number of these stem cells goes down, or sometimes the severity of the injury or damage is more than the ability of your body to repair it. This leads to an imbalance and ultimately leads to arthritis, injuries, and pain. In essence, as you age, you have a lower number of contractors and workers available to do the job, or sometimes the amount of damage is too much for the available stem cells. But fortunately, there are areas of your body that keep a good number of stem cells. These areas include the bone marrow of the hips and the fat in your abdomen and buttocks. And this is the key to stem cell therapy. The doctor will take stem cells from one or both of these areas and transfer them to the area of injury or arthritis. This will provide the stem cells needed for repair. In essence, the treatment will supply the manpower needed to do the job. Once there, these cells secrete growth factors that will organize and coordinate other cells to do the repairs. This leads to healing. This is like the contractor giving instructions to get the job done. This treatment can be used for pain with injuries coming from ligaments, tendons, muscles, bones, cartilage, and meniscus. When is it useful? If you have an injury or an arthritic condition that did not improve with therapy, medication, other injections, or surgery, or if you were told you need surgery, then stem cells is a great option for you. Thanks for watching.
Okay, so we're back now. So when we were 10 years old, pretty much 1 out of every 200 cells circulating around in our body was a stem cell. When you hit 60, 1 out of every, 200. When you hit 60, it's like 1 out of every 200 million. So you lose some stem cells as you age. However, there are these areas, as it talked about in that cartoon, where we still have huge numbers of stem cells. And that's where we basically harvest them from. I harvest them from bone marrow and from fat. And I take platelets from blood because platelets are basically, there's the great little packages of growth factors and cytokines and exosomes, and pure and simple, they're fertilizer for stem cells. And that's the gold standard. You want to do all three, and you only want to use them from your own body. So as far as the joints that we treat overall, of all the thousands of patients that we've done, we're sitting at a basically 91% of our patients are improved significantly. If we look at total joint, took a look at big data on total joint replacements, 65 to 70% of patients are happy with the results. That means, though, 30 to 35% are not so happy. And the thing with total joints, you could end up with pain that is worse afterwards, and then it's an end game. There's nothing else that you can do. There is always a risk with total joints of infection, blood clots that can break off from your calf and go up to your lung, heart attack, stroke. Total joints don't last forever. They do loosen. Knees, we're looking usually, depending upon size and activity level and weight, anywhere from 12 to 15 years. There are some studies being presently conducted, kind of looking at, is there an increased incidence of dementia with after total joint replacement because of chromium, cobalt, and nickel. And that's metal that gets absorbed into your body. I probably see 3 or 4 patients a month who come to me because they've had a total knee a year or 2 or 5 ago, and they're just not happy. They're miserable, and they want me to do stem cell therapy. And I said, well, it's a little too late, because all you've got now is metal and plastic in there, and stem cells aren't going to do any good for that joint. What we do before the procedure, it's fairly simple. We have patients, we want people to be well hydrated. We want them to drink a lot of water beforehand. We like to avoid anti-inflammatory medication, because the way this whole process works, we heal, our bodies heal by virtue of inflammation. You need inflammation to heal. So we don't want to take anti-inflammatories. So we have people stop those about a week before, and then for 6 weeks afterwards. The only medications that we're concerned about is if somebody's on a blood thinner. Usually we can deal with that. We have them stop for a day or two before the procedure, and then they start it back the day of the procedure after the procedure itself. What we do, the first thing we do, patients come in and we draw blood. From the blood, we basically, it goes through a centrifuge, it layers out, we pipette off an area or a section of that, which is called the buffy coat. The buffy coat is all platelets. We take that, we set it aside. We then do bone marrow aspiration. Now, the bone marrow aspiration where I do it, so basically you've got your spine in the middle, and then you have your pelvis on either side, kind of in your flank area. We numb it up, we go down to the bone, numb up with local anesthetic, and then I use something called a Jamshidi needle to work my way through the bone down into the trabecular portion of the bone. So if you picture the bone like a Whopper, a chocolate-covered malt ball, we're going through the chocolate, and once we get down to the malt, that's trabecular bone, and that's where we get the bone marrow. That's where we draw the bone marrow from. People are always concerned about the bone marrow aspiration because they think it's going to be very painful. I would say of the thousands of patients that we do, half the patients are like, "Are you kidding? You're done already?" And half of them are like, "Oh, wow, I can really feel that. It feels like sciatic nerve pain going down my leg," or it feels like, people sometimes describe it as a deep, kind of like a hollow vacuum type sensation. However, it takes me less than a minute to do the bone marrow aspiration. So if you're in that 50% of patients who has discomfort with it, it's very short-lived. Once that needle is out, the pain is gone. We then do a mini liposuction, kind of in the love handle area, very close to where we do the bone marrow aspiration. And that, we numb it up, we use saline. Most people don't feel that at all. If anything, maybe they feel a little pinching sensation. The reason we get stem cells from both areas, the stem cells that we get from bone marrow are very robust and long-lived. The stem cells that we get from fat are prolific. We get tons of them. And we also like to have that matrix, the collagen matrix of fat, which helps those stem cells adhere to the bony surfaces in the joint. I don't do fat when I'm doing tendons and muscles, and I don't do fat when I do small joints like the thumb joints in the hand or the toe joints. I just do either just bone marrow alone or I do PRP alone. So after, the nice thing about the system that I use was developed by a buddy of mine who ran the molecular biology department back in California at Stanford. He was a brilliant guy, and he figured out the software program that enables us to get those mesenchymal stem cells, just those, in billions. So we get huge numbers of stem cells, which then, under ultrasound guidance, we inject to the area that we're treating. Basically, so if we're doing a shoulder or we're doing a knee, it's one needle, and then it's 3 separate syringes: the syringe from fat, the syringe from bone marrow, and the syringe with the platelets. That portion of the procedure can be a little uncomfortable. It usually feels like a balloon filling up. It's like we're putting a lot of cells in there and a lot of fluid. And then that's the end of the procedure. We get the patient up, moving around, walking, moving their arm or shoulder. Patients do need a ride because we do give you pain meds. But you walk out, and with lower extremities, hips and knees and ankles, very rarely do I put people on crutches, sometimes just for comfort for a couple of days. Shoulders, upper extremity, pretty easy. People go back to activity the next day. I mean, activity is a daily living. Yeah, I don't want you to go run around Green Lake or anything like that, but usually we start physical therapy a week after the procedure, and by 2 weeks, most people, at least people who are having hips and knees and ankles, they're spinning on a stationary bicycle, and then they're progressing to an elliptical, and then they're progressing, to balance and proprioception and agility. By 6 weeks, most people are starting to see improvement. In the 6 to 12 weeks, most people are starting to see improvement. Improvement tends to go out to a year and then tends to level off. Some data out of Japan actually says 2 years. Who shouldn't have the procedure? Blood thinners. We do the procedures on patients with blood thinners. We just usually take people off, but I always like to know about it so that we can, sometimes with hips, with deep joints where we have to go through a lot of muscles, we'll want them definitely off the blood thinners for a couple of days. Some of the other joints, it's not that big of an issue. If somebody has an active infection, and say they're on antibiotics, they got pneumonia or they got sinusitis or cellulitis, we don't do the procedure when somebody is actively infected. And if somebody's undergoing chemotherapy and being treated for cancer, or if there's any type of metastatic disease, then I need to have a conversation with the oncologist before we proceed on. And it varies. Prostate cancer, not a big issue, but other types of cancers, that's something that I need to get more information from the oncologist. Unfortunately, there's a lot of people out there who are doing this procedure I know there's a lot of chiropractors and naturopaths who they can't do injections. They hire nurses or nurse practitioners to do the injections. They buy stem cells online, either amniotic fluid or embryonic, and it comes from women who are willing to sell their placentas. most of those come from south of the border. It's kind of a sketchy patient population. We know that there are no live stem cells in that product. They come desiccated, and then they're reconstituted with sterile saline and then injected. So I would be very careful about seeing anybody who doesn't have a lot of experience in this and who is not using your own stem cells. I've seen some real disasters in patients who have gone elsewhere and had it done with what we call allografts, and that's stem cells that come from somewhere else. So big data says that patients with mild to moderate arthritis, 85% of those patients see at least 80% improvement. We see 91% of our patients get at least 75% improvement, and that's what we call patient-reported outcomes. So when at 3 months we ask everybody, and then again at 6 months, if you were a 10 on a scale of 1 to 10 before we did the procedure, 10 being the worst as far as pain goes, where are you now? And we like to hear, oh, I'm like a 2 or a 3, and that's the hope. That's kind of where we're shooting for. Sometimes I do patients who have severe arthritis. I get referred a lot of patients because some people just say, doc, there's no way in hell I'm going to have a total knee replacement or a total shoulder. Even though I know that I'm bone on bone, I'm, got terrible arthritis, but I'm not having it. Or maybe they're not having it because they've got some cardiac issues or issues with obesity or diabetes, or they have some other medical problems that is not making them a good candidate for surgery. So even though I see people and I say, we might want to look at a total knee replacement, some of those patients say, hey, I'm not going to have a total, but I'm willing to live with a, maybe a 65 or 70% chance of seeing improvement with stem cells. So there are quite a number of studies out there and conclusions from scientific journals, and I recapped a few of them. From the Journal of Bone and Joint Surgery, it says there was evidence of meniscus regeneration and improvement in knee pain following treatment with human mesenchymal stem cells. These results support the study of human mesenchymal stem cells for knee tissue regeneration and protective effects. From the Journal of Clinical Orthopedics and Trauma, the versatility of stem cells as a treatment modality has landed another repair target, osteoarthritis. Through many studies, this newly discovered method has been shown to significantly alleviate the pain experienced by osteoarthritic patients. From Helion, this study showed that a single intra-articular injection of bone marrow stem cells appears to provide long-term benefits. The procedure is simple, fast, well-tolerated, avoids the need for hospitalization, and generated no complications or adverse effects. There have been over 35 million cases done in the United States. As long as you use your own cells, there have not been any severe adverse effects reported on the FDA database. From Journal of Orthopedic Translation, in contrast to traditional treatments based on drugs, proteins, antibodies, stem cells are poised to revolutionize medicine as they possess the capacity to replace and repair tissues and organs such as osteoarthritic joints. Nature, which is the British Scientific Journal. In conclusion, mesenchymal stem cell treatment improves knee pain, physical function, and cartilage quality without any severe adverse effects. I think this is the last one, showed that cartilage mapping by MRI showed evidence of improvement in good cartilage quality and decrease in poor cartilage quality. This was that study. Showed that basically there's a procedure called microfracture surgery that people have, usually knees and ankles. And basically what it involves is drilling a lot of holes through the area where the cartilage is gone, in hopes that bleeding will provide some cells that can lay down some new scar cartilage. Typically, I don't see it working very well. And that's basically what this says, is that bone marrow aspirate, which is BMAC, has significantly better results than microfracture surgery. Yeah, now there's over 35 million cases done in the United States. So basically, the procedure itself is, it's local anesthetic. You're awake, listen to music. Takes about an hour. The whole process, as far as harvesting the cells, basically concentrating this, isolating and concentrating the cells, and then injecting the cells into the joint itself. No general anesthesia. We use just pain meds, oral pain meds and local anesthetics. So patients go home, whatever's comfortable, walk around. We don't want you just sitting and not using the joint. We do start physical therapy the following week. We like to get people back and active as quickly as possible. And usually at 6 weeks, most people are back with weight-bearing joints like knees and hips and ankles. They're back to hiking, golf, easy skiing, things like that, whatever they're able to tolerate. And then at 12 weeks, I tell people whatever feels okay, because those cells are rock solid by 12 weeks. We're not going to damage anything. In the first 6 weeks, those cells are a little fragile. They're immature cells. They're juvenile, and we want to protect those. Now, that doesn't mean you can't walk on it, but yeah, I don't want you jumping, running, cutting, pivoting, twisting, in the first 6 weeks. But as we progress on, we start to increase the activity level to the point where, we get back to hopefully significant activity and with much, much less discomfort. Occasionally, we do get MRIs, more so on anecdotal cases where people come in years later and had another injury, and we end up getting an MRI and we say, oh my gosh, look at this. There's been significant improvement in your osteoarthritis, or we don't even see that osteochondral defect, that hole, that crater in the cartilage that was there, or we don't see, the evidence of the meniscus tear that was there, or the partial rotator cuff tear. Now, granted, there are not a lot of large randomized studies out there because basically, in order to do a double-blind randomized study, the patient and the physician do not know who's going to get their own stem cells or who's going to get sterile saline with red dye in it. And then you have to wait. It can be anywhere from 3 years to 5 years, to look at the results. There's not a ton of people that are jumping, chomping at the bit to sign up for those. So there aren't super large studies, although they did a study at NIH in Atlanta where they have this mega scanner, and it was on knees, and they did monthly MRIs in this research scanner after stem cell procedures. And they could see statistically significant increase in the thickness of the articular cartilage at 3 months. So we definitely do see the regeneration of cartilage. And then when we're treating muscle and tendon, we definitely see regeneration there. Now, granted, complete tears of like anterior cruciate ligaments and acute complete rotator cuff tears where all of a sudden you can't move your arm at all, then oftentimes those cases require surgical intervention. So I think we're going to open it up. A lot of times we get a ton of questions, and we're able to really delve into specific joints that we treat, specific cases that we treat, the results that we get. So I'm going to start looking at some of the questions I think that people are putting in now. Okay. So let's see here. Okay, so I have a torn labrum and mild arthritis in the hip. I'm a very active 62-year-old in very good shape, hike 6 to 10 miles a week. So oftentimes we see labrum tears in 20-year-olds. You know, it doesn't have to be somebody who's got arthritis in their hip. The earlier you catch osteoarthritis, if you catch osteoarthritis in the mild and mild to moderate, the results are significantly better. And oftentimes we can totally eliminate the need to ever have to talk about surgery if we jump on these and treat them fairly early. The labrum, same thing. We treat a lot of labrums and osteoarthritis together, and oftentimes it's like a chicken and egg type thing. Did the tear in the labrum cause the osteoarthritis, or did the osteoarthritis cause the tear in the labrum? I'm going to move on to the next question. I have osteoarthritis in my spine, which is pinching on nerves. Is your treatment able to address this? I myself don't do spine. I do sacroiliac joints and then I do joints, but I don't actually do spines. Now, stem cells do treat certain degenerative changes in the facet joints and in the discs. It all depends kind of what the MRI looks like. The data isn't quite as robust as it is for joints and for ligaments and tendons and such. Okay, scrolling down. The slides are available after the webinar. I think it gets put on YouTube. Yeah, it gets put on YouTube. So it can, if you pull up my name and stem cells, there's probably about 5 different webinars out there. Okay. I am currently in Panama and considering umbilical mesenchymal therapy. Why would you talk me out of that? I have frozen shoulder and biceps tendonitis. PT and 3 cortisone shots have not helped, and doctor said surgery is not needed. Pain is brutal. I want to surf and golf. All right, I'm right there with you. I want to surf and golf too. So basically, umbilical. So what they do outside the United States is they use umbilical or they use embryonic, and they culture stem cells to try to increase the numbers. They also subject those cells to what's called enzymatic degradation under like hoods in labs. It's called obtaining it's called the stromal vascular fraction. The reason that you haven't been able to do that in the United States, and there was a company that was doing that in the United States about 8 or 9 years ago, and they got fined big dollars, and they moved to the Cayman Islands. Now they're back in the United States. But there's a theoretical concern that if you manipulate stem cells outside the body, you can damage the telomeres, which are the ends of the chromosomes. Then there's a potential for malignancy. So that's why you don't want to manipulate stem cells. And the nice thing, the system that I used gets us such high numbers of stem cells that we don't need to take that risk as far as culturing cells or subjecting them to enzymes. Can stem cell therapy be used with arthritis in the big toe? Absolutely yes. So now I see in parentheses this individual mentioned that they have hallux rigidus. If that joint is completely fused and doesn't move at all, probably not. But if that joint still has a joint space and there is some movement there, then yes, we do those all the time. And actually, we also do the analogous joint, which is the base of the thumb. It's called the first CMC joint. I have personal experience with that. I have arthritis at the base of my thumbs, and this was probably 9-10 years ago. I was absolutely miserable. planning ski poles, tennis, fly fishing, and I would have one of my partners do a cortisone injection. And if I was lucky, I got 2 or 3 weeks of relief. So finally, I said, the hell with this. I went back and I had one of my buddies in California do stem cells on my thumbs. It has now been just about 8 years. And my right one is, I would say it's 100%. I have no issues whatsoever. My left one, I'd say, is 85. I can make it hurt, on certain days, but it doesn't stop me from doing anything. What is the success rate for cervical vertebrae? Is there additional procedure necessary to help align the vertebrae? Boy, I tell you, it would all depend on what the MRI looked like. And I have people in Portland and in Vegas and California who do a good job with spine, colleagues that are down there. There's really nobody in the Seattle area that I would recommend for that. So if you want to contact our office, we can give you that information. This is a good question. Is it covered by insurance? It is not. Physical therapy is covered. Follow-ups are covered if you have like a health savings account or flexible spending account, then you can use those type funds. But it is not covered by insurance. A lot of professional athletes get it covered. That's a little bit of a different story. The pricing for it varies in different parts of the country. Probably California, Colorado, and New England is the most expensive. The least expensive area is actually a buddy of mine who runs the program at Emory. And where our pricing is in the middle towards the more affordable side of things. So then the next question is, for wrist and thumb joint, only PRP, no stem cell treatment? It all depends on how bad that joint is. That joint will only accept about 2.5 cc's. So if I do stem cells regenerate tissue. PRP decreases inflammation. So typically I'll just do bone marrow in that joint. And sometimes if patients are still having discomfort at like 3 months later, sometimes then I'll just put some PRP. There's just not enough room in that joint to do bone marrow and PRP together. Aside from pain, a rotator cuff tear also limits motion. Does this procedure improve mobility of a bad shoulder in addition to pain? So if it is a complete rotator cuff tear and you have limited motion, it's most likely not going to bring back full range of motion. It definitely, so kind of the way stem cells work in partial rotator cuff tears or chronic complete rotator cuff tears, where at that point, patients usually have significant arthritis and have a chronic rotator cuff tear and a labrum tear, and their only option is a total shoulder replacement. In those cases, pain is the thing that is improved initially, and then with subsequent physical therapy, we do see improvement with range of motion and strength. Next question, can you have 2 joints done at one time, i.e. knee for meniscus and osteoarthritis in the toe? Or maybe knee for meniscus and osteoarthritis and toe for osteoarthritis? Yeah, definitely. We probably do more double joints than we do single joints because patients always have more than one thing going on. We even can do 3 joints at one time, but that's the most stem cells that we take is 3 large joints. The nice thing about doing joints at the same time is you basically go through the therapy at the same time. It really doesn't take that much longer, and it does save patients a lot of money. So it ends up, like in the case of if you do 2 knee joints or a knee and a shoulder, it saves patients about $5,000 because we are able to just open one kit that's designed for 2 joints. Every time we open these surgical kits, it's a huge expense. How do you decide who's a good candidate? We just do consults and I look at films and images and do exams and see kind of How is this joint affecting life and the patient? And we always talk about what the options are, either surgical or non-surgical. We have a lot of people who live all over the world, and we do telemed consults or Zoom consults, and we get their images. So that's how I tell. It's a multifactorial decision where we look at images, get history, do physical exam, and see what patients' hopes and expectations are. Do you need an MRI prior to surgery? So first of all, this is not surgery. It's a procedure. It's a minimally invasive procedure. Patients end up with a very small incision in their lower back, which is just closed with a steri strip. And then as far as in the joint, it's just the needle. So it all depends. Sometimes an X-ray shows me osteoarthritis, and then we don't need to do an MRI. However, if we're looking at meniscus or labrum or muscle and tendon tears or osteochondral defects, then oftentimes we'll get an MRI. Unfortunately, back to the insurance issue, it's not covered by L&I. So we do see a lot of L&I patients who just say, hey, I want to have stem cells. I understand that's not covered by L&I, so they go basically outside that. So somebody wrote stem cell versus PRP versus laser. I do a ton of just PRP on its own. It's more so for tendonitis, tennis elbow, Achilles tendonitis, patellar tendonitis, muscle injuries, contusions, patients who come in and they've got this knee pain that's been chronic. They've gone through everything. And they have normal X-rays, normal MRIs. It's usually women runners. And they come to see me because they want to do stem cells. I say, we don't need to do stem cells. We're not trying to regenerate anything, but what we do need to do is decrease the inflammation. And in those cases, we do PRP. Laser, I'm not great. I haven't seen great results. Laser. Sometimes laser and physical therapy is a good issue, but I don't think laser is going to take care of other issues. In Seattle area, is Dr. Wagner the only physician who does stem cell and PR? No, there are other people who do stem cells in the Seattle area. Not a lot of people. I don't know if there's anybody on the peninsula or on the I-5 corridor or the I-90 corridor until you get down to either Portland or Spokane. We see a lot of patients from Alaska, Montana, Idaho, Eastern Washington, the peninsula. Because there's nobody else kind of doing the procedure out there. Is there any evidence of effectiveness for spinal stenosis? No. So with spinal stenosis, we've got excess tissue, and that, if it's causing significant problems as far as cord compression, needs to be dealt with surgically, and stem cells are not going to do anything for that at all. Is being significantly overweight a factor? I had a guy in the office today who is significantly obese. He has been told he needs to lose at least another 50, 60 pounds before having surgery. And he's plateaued. He's got such bad knees, he can't exercise. He can't lose the weight. We're able to do the stem cell procedure in overweight patients. So that is not an issue. We see a lot of people who, it's a vicious cycle. If your ankles, your knees, your hips are hurting, you can't walk, you can't exercise, and it's hard to lose the weight. So oftentimes we do the procedure. We had a woman in, I think it's about 6-8 months. She was in one of those motorized wheelchairs, hadn't been able to walk for years. And I think we ended up doing like her hips and knees. And she came back to see us in tears because she was just so absolutely thrilled with the fact that she could walk now and get out of her motorized wheelchair. Never thought she was going to be able to do that again. I am 68, end-stage osteoarthritis in my knee, bone on bone. So I'm going to actually address that right before I read the rest of it. I bet 95% of the time that patients come in to see me and they've been told, or they get the impression that they're bone on bone. We sit down, we look at the films, and they're not. And there's some of the surgeons love to throw out the bone on bone. I had a woman in today, thin runner, who was told, oh, you have bone on bone, you're going to eventually need total knee replacements. I said, look at these films. You've got great joint space. I mean, you got mild to moderate at worst osteoarthritis. So I'd be very hesitant when you're told that you're bone on bone and maybe get another opinion. So the rest of this, I also have a 40-year-old unrepaired meniscus tear in the knee. I ski. I'm looking at total knee replacement surgery. You're 40 oh, no. The injury is 40 years old. I am looking at total knee replacement surgery within the next year or so. I'm not thrilled about the surgery. And no, it requires major recovery. I think you're definitely a candidate. I think what we need to do is see how bad the osteoarthritis is. Is it truly bone on bone? And then kind of go from there. I mean, yes, total knee replacement, it's a big surgery. It's a year of rehab. And, not without potential complications. Now, I don't know until I actually see the films, if you're truly full on bone and have significant deformity in the knee, maybe you might be a good candidate for a total knee replacement. But that's something that I would say, would be worth at least getting a consult. So success rates for stem cells versus knee replacement, all depends on what stage, where you are as far as osteoarthritis. Anywhere from 65 to 80% of patients see very significant improvement with stem cells. Stem cell therapy has been around for many years now, still does not have FDA approval. It seems that it should be close to FDA approval by this time. What's the situation with FDA approval of this procedure for osteoarthritis? There's a lot of politics involved. Total knee replacements make ambulatory surgery centers, hospitals, prosthetics companies a lot of money. And so it's kind of like the old saying, if all you have is a hammer, everything looks like a nail. So, a lot of people do a lot of total joint replacements. And the procedure it's basically, it's FDA cleared, it's FDA investigational. If you look at places like Mayo Clinic, Cleveland Clinic, Hopkins, Harvard, Stanford, Curlin Jobe and Stedman, the two largest orthopedic centers in the country, they're all doing stem cells because they work. Eventually, it should get approved by the FDA. I've talked to people at Blue Cross and that I know and Premera, and they don't see it on their radar screen yet as being covered. How long does it take to know if it's been effective in reducing and eliminating pain? Most people start to see improvement in the 6 to 12 week range. Improvement goes out to a year, although some data out of Japan says 2 years. Says, I wish to avoid surgery and can afford to go naked. In other words, without insurance payment. But the lack of FDA approval concerns me, mostly about provable success rates, not danger. I actually have there's a study here that is not in the slides yet because it's a fairly recent study. This is the largest study done on stem cells over a 2-year period of time, a couple guys out of Harvard, and they basically reviewed 34 peer-reviewed journal articles on the results of studies. And their conclusion was that mesenchymal stem cell injection provides consistent, clinically important improvement in osteoarthritis disease parameters, both in magnitude and duration of improvement, and that it far exceeds any improvement that may be seen from either placebo effect or other conservative measures. Furthermore, the duration of efficacy out to 2 years from a single treatment greatly exceeds that of any other non-surgical treatment and possible placebo effects, particularly in light of its excellent safety profile and the absence of other safe, effective treatments for osteoarthritis. Mesenchymal stem cell treatment should be widely adopted for the treatment of osteoarthritis. So That's basically what I go on, and that's what I see in my own practice. Some of these other questions. If I have a bone spur in the AC joint that causes pain in the tendon, can this help? I had an MRI, torn labrum, torn rotator cuff, mild. Yeah, I mean, absolutely would help. Oftentimes, people always get the impression that a bone spur or osteophyte is causing the issue. Most of the time, it's not. Typically, those spurs or osteophytes, they form on the periphery of the joint, and they're not causing issues within the joint. So you don't need to go take them out. I mean, what's most likely causing the pain here is more so the torn labrum, the rotator cuff, and the arthritis within the joint. If you have a blood disorder like thalassemia minor, would that have an effect on success? No, that's no problem whatsoever. You still got platelets. Thumb arthritis. I was talking about my own thumbs. How long would I expect treatment to last? I'm 8 years out doing just fine. Will you take medical records, x-ray? Yeah, I mean, we have patients that send their images all the time, and we review those, either if they're like across the country or if they're in different places, we can review them by getting them online or in the mail with a disc, or we take extra. We have radiology facilities at our office if we don't have recent images. What if you are in your mid-70s? Most of our patients are. So, you still have significant numbers of stem cells in the billions. We have over 200 patients that we've done in their mid-90s who have done just fine. What keeps the injected stem cells and PRP materials in the joint? Why aren't they simply washed away in the normal circulation of blood? So there's a capsule that surrounds the joint. And once we're inside that capsule, which that's why we use ultrasound guidance so we know exactly where we're going, those cells stay within the capsule. Yeah, do a few leak out, probably through basically the injection site, but we're putting in, 2-3 billion of those cells. So they pretty much stay intact there. If the knee replacement isn't working, if the knee procedure isn't working for you, are you still a candidate for knee replacement? Yes. So basically, if you fall into that 10% to 15% of patients who maybe don't see significant improvement, a knee replacement or joint replacement is still a viable option. We talked about this as far as the procedure being covered by insurance. It's not. Typically, a procedure for a knee runs anywhere between $5,000 and $10,000. That's can be even 2 knees. So like a single large joint is right around $7,500. If you do 2, it's usually 10. Can you have repeat injection? Yes, I have done. Boy, of the thousands of patients that we have done, I've repeated. I can think of the ones I've repeated probably and count them on one hand. And they're all unusual cases. One is a guy who's an ultra marathoner, horrible knees, but his bucket list goal was to run the Western States 100-miler across the Sierras. So we did his knees. He continued to train and run, and he came back to see me 3 years later with his. So basically, with the Western States 100, if you finish it within 24 hours, you get this belt buckle. So he brought me in to show me his belt buckle. He said, "Doc, my knees are killing me." He goes, will you do them again if I promise you I will never run again? He said, "I'll sign a contract if you want." I said, "All right, we'll do them again." So we did them. He's cycling now. He's swimming. He's doing great. Another one is she's a very famous professional tennis player. She came back to see me after a year. She said, "Doc," she goes, "I want to do my knees again." I said, "Oh gosh, are they bothering you?" She goes, "No." She goes, "They're great." She goes, "I just want insurance." And I mean, she has more money than God. So I said, "Well, I don't know that it could make that much difference," but she wanted to do it. So we did. And the other one that I can remember is a lady who was like 2 years after her procedure was in a motor vehicle accident and her knees impacted the dash. And she won. And in that case, it was covered by insurance, but it was motor vehicle. So we did her again. She's doing just fine. It is significantly, patients say, is it cheaper than total joint surgery and rehab? Yes, significantly so. However, total joint surgery, usually 80% is covered by your insurance. But usually the deductible or the portion that's not covered tends to be more than stem cells. If I have pretty severe osteoarthritis in the knee and also 2 tears in the meniscus, I get bouts of severe stiffness in the leg. What are the chances that stem cell therapy can help me? Probably pretty darn good. Once again, it depends on looking at those images and examining the knees. But, as long as we're not looking at severe, joint space obliteration, you might be a very good candidate. I have remnants from an old shoulder separation, and weightlifting causes soreness, which lingers constantly in the front area of the shoulder, which is not in the area of the separation. So I think what we need to do is look at the rest. We need to look at the labrum, the cuff, and the glenohumeral, the big joint, the ball and socket joint, and see. Most likely there's something else going on. Assuming a rotator cuff tear is a candidate for stem cell treatment, how often would the procedure be required? The plan, the hope is one and done. I mean, very rarely do we end up having to repeat the procedure. I have pain in my shoulder, I believe from repetitive motion from pulling a stiff seatbelt in my truck that has been replaced. I have reduced strength and motion, but the shoulder is still workable. It seems to be straining the muscle around it. Is this normal? Using an ice pack and some ibuprofen and a TENS unit. Once again, it all depends, on what an X-ray and possibly an MRI would show to see if there are some partial tears in the rotator cuff or the labrum, or if there's osteoarthritis in that joint. So I would suggest, a consult to see. How long do you recommend waiting until a trip to Europe with 15 to 20,000 steps daily? I'd say 6 weeks. Also, if after some years, say successful results, if the arthritis returns, can stem cell injections be repeated? Yes, they can be repeated. And even repeated again after more years, yes. I mean, you have plenty of stem cells in your bone marrow, and they heal and they replace themselves very quickly. The Panama person says, thank you, I'll skip Panama and see you in Seattle. Can you treat injuries to a sagittal band? I guess I don't know what a sagittal band is. If CM, who put this in there, could kind of elaborate, I'll scroll down and see what that is. What about shoulder rotator cuff damage, tendons with arthritis? Absolutely, we see great results with that. We did talk about the pricing. My husband had a PRP injection in his ankle. It was unbelievably painful in Los Angeles. The ankle joint is pretty darn bad. So tough thing with ankles. Oftentimes when ankles come to see me, they're at the point where either they just have a small osteochondral defect and they have a little bit, pain, they can't run, they can't play soccer, or they've got horrible ankle arthritis and their only options are fusing the ankle or having a total ankle replacement. Typically when we do the injections, they're not that painful. I mean, they're uncomfortable. That's why we use the ultrasound to get that needle into exactly the right place we want it. And our results with ankles are pretty darn good. I can't really even think of patients that have gone on to have a fusion or a replacement after stem cells. Thumb joints, somebody's saying cost. Thumb joints are a lot less expensive. I think we're looking at somewhere around $3,500 roughly. Cost for 2 shoulders is 10 and change. My son had a flag football injury a few weeks ago. Somebody landed on his Achilles. He heard a pop. Pain is minimal. He's using an Achilles boot to help with walking, but he is mostly resting. He still has range of motion, but bruising is common. Is stem cell consideration? If he has a complete tear of his rotator cuff, no. Then he needs surgery. So I can tell if there's a complete tear just on physical exam. If it's a partial tear, absolutely. And you want to do it as soon as you can, because we don't want him to go on to a complete tear, because then oftentimes it's a big surgery, it's a long recovery, and it's fraught with a lot of scar tissue and maybe chronic issues going forward. I had meniscus repair surgery 10 months ago, slight improvement, but I want to feel better. So most of the time that patients are told that they had meniscus repair, it usually means they went in and took out the meniscus. And oftentimes patients still do have pain, or they have a recurrent tear, or because meniscus just doesn't have a blood supply. So therefore it's never going to heal on its own. So you can put sutures in it all day long and it'll never heal. So yeah, I would say, you know, at least for sure, getting a consult and seeing if you are a candidate. Also, if not too awkward, are you aware whether Dr. Dan Nelson in Kirkland or others in Seattle are using the same procedure? No, I don't think they are. I think they do it a little bit differently. I used to be with ProLiance before I started my own office independently. I think they use different systems. I don't know exactly what they're using, what, you know, centrifuges, software programs, or anything. So I couldn't tell you exactly what they do there. I am 22 years with a history of seven surgeries and a patient of Dr. Wall. Diagnosis of discoid lateral meniscus, most recently having surgery in August. I've had Oates procedure, osteotomy, bone grafts with iliac crest and patella lengthening. Still have significant pain in the lateral side of my knee. Films are clean. Osteotomy is healed. Curious. Yeah, I think PRP would definitely be a good idea on this. And have you had a recent MRI? It sounds like probably you have. But yeah, PRP certainly would be a good option. Calcific tendonitis secured with stem cell therapy. Yeah, I mean, we treat that all the time. Typically, when you have calcific tendonitis, it's usually because you have bleeding in the tendon, and within that tendon itself, you then form calcium. And it's not like bone, like hard calcium. It's more like toothpaste is what it is. But no, I mean, we see good results with that. So somebody's saying, what's the cost for one joint versus two joints versus three joints? Basically, you're looking at like 7,500, 10,000, 15,000 for one, two, and three. So there's significant savings if you do more than one joint at a time. Success with stage 3 to 4 bone-on-bone hip joint. Have you done many? Yeah, I've done plenty like that. Once again, I gotta see the films though, because stage 3 to 4 is a big range, and I just need to see what things look like. What does it cost to come in for an evaluation? That's a good question. Insurance covers consultations at my office, unless you're like on a PPO plan with Kaiser, where I'm not, you know, an employed physician by Kaiser. But for the most part, you know, all the major insurances cover consultations. Can stem cells be used for patients who have rheumatoid arthritis, if the destruction is slowed by a biologic? Yes, we do a lot of those. I get referred a lot of patients from rheumatologists. The stem cells themselves are not going to treat the rheumatoid arthritis. However, they will treat the arthritic destruction within the joint itself. And patients can stay on their Enbrel or whatever biologic that they're on. We end up doing a lot of those. But once again, I always tell people, this isn't going to automatically, you know, treat the rheumatoid arthritis, but it will treat the damage caused by the rheumatoid arthritis in the joint. What is the longevity? Do people get relief, but efficacy wears out? So yeah, I've been doing this 8 years. I've got plenty of patients out 8 years doing just fine. Ornstein has been doing this longer than anybody in the country, like 19. She's got patients who are out 19 years doing just fine. She also has patients that, you know, at 10, 12 years, maybe end up having the procedure repeated. Let's see. So yeah, there's somebody's asking about the wrists and the base of the thumb. It is less expensive for just, if it's just like the base of the thumb. If it's like the entire wrist joint, basically, that usually ends up being like 3 or 4 joints, and that tends to be more a large joint cost. I have patients go to PT start out at 3 weeks. Some people do fine just twice a week for 3 weeks. Some people end up going 6 weeks. Somebody's asking, is the SI joint eligible? Yes, absolutely. We see really, really good results with SI joints. Would stem cell therapy be something to consider after having rotator cuff surgery to attach one tendon and repair tears and damage? Surgeon stated he had to be creative in doing the repair. You know, there are places in the country, although Seattle is not one of them, where you use stem cells intraoperatively in a biological dressing to basically increase overall healing, decrease healing time, and provide a better repair. So, but nobody up here is doing it. And I have a lot of patients who do exactly what you're doing. They go, or I'll tell them, hey, you got a complete rotator cuff tear, or you got, an ACL tear, and you got this meniscus. Go have the surgery, and then come back to see me 6 weeks after the surgery, and we'll do the biologic procedure. Our consults, the nice thing is I've got a huge office with just me. Until my son joins me in 3 years, he's in the middle of doing his residency. But right now, we get people in we can get consults in usually within a week or two, and we can get procedures in within a week or two. I was with big health systems for a while, like UW and Swedish, and I absolutely hate it when I tell my front desk, if somebody can't get in, if you can't get them in within 2 weeks, come talk to me, because we'll make it work, because I can't stand when patients have to wait. I see a ton of people from Canada. I see a ton of physicians from Canada, because they're looking at a year to get a doggone MRI in Canada. So they fly down, and we do the work up here and do the procedure here, and then they fly back and do their physical therapy back in Canada. So let's see. My husband had a severe injury to his ankle in his 30s, never got complete movement. At 72, he fell off a ladder, shattered the same ankle. He's still limping in pain. The arthritis seems to be the remaining problem. He had one very painful PRP injection. Doc recommended ankle fusion, which he doesn't want to do. Yeah, I say with this background, mesenchymal stem cell injection, you said, is it worth a try? I would say yes. However, once again, I would want to see images and see the joint itself. If arthroscopic surgery has already been performed for a medial meniscus tear, can stem cells rejuvenate the cartilage? So if they took out a portion of the cartilage, it's not going to replace what was taken out. However, if there are degenerative changes in the meniscus or tears in the meniscus, then yes. Oh, okay. This is the sagittal band. So this is basically the tendon, and I'm assuming that it's it could be the flexor tendon or the extensor tendon. Somebody's wondering about the sagittal band. I guess it depends on how long it's been since the injury, and what the MRI looks like. But it might be a good option for it. I would need to definitely see an MRI on that. Would this be effective for a horizontal degenerative tear in the meniscus? Absolutely, because with horizontal tears, I call them fish mouth tears. Those tears, they go back quite a ways, and so you just go and with surgery, you bite out, you probe, you bite out more, you probe, and you could end up taking out 50 to 70% of that meniscus. Whereas with stem cells, we can heal the doggone thing and leave that meniscus there, which is important because 85% of patients who have meniscectomies are going to end up with osteoarthritis at some point in their life. If I have knee osteoarthritis and medial meniscus tear, how do cells know to differentiate into articular cartilage and meniscus? That's a great question. So we can't program them. Elon Musk will figure it out someday, but we don't know how to do that. They know how to do it. They basically, and where this is to me fascinating is in a shoulder. So when we have somebody come in with a rotator cuff tear a labrum tear, and osteoarthritis. Those cells differentiate to 3 different cell types and basically heal all 3. They're like, kind of like that cartoon said, they're like little general contractors, and they know what to do. Somebody's asking, what's the cost of stem cell therapy for medial meniscus tear? So a large joint is a large joint. It's still like, I think, $7,500. For a knee stem cell replacement, is the type of physical therapy strength or movement or flex? So it's all 3. And it's just at different times as we progress on through physical therapy. We work first with, range of motion, then strength, then proprioception, then agility. All 4 tendons are damaged along with arthritis. I'm assuming these are all 4 rotator cuff tendons. Yeah, as long as they're not completely torn and retracted a significant amount, then yes. So full thickness tears in the rotator cuff, like the number 1 tendon that's involved is usually the supraspinatus tendon. Full thickness tears we treat all the time with stem cells. Now, if they're full thickness and full width, meaning the whole tendon is pulled off the bone and it's retracted, then if it's acute, if it just happened, like within, say, maybe 6 weeks, usually you can surgically repair those, which is the best way to do it. However, a lot of times they're chronic. They've retracted so far that there is no way in heck that you're going to be able to get them back together surgically, or with stem cells. And in those cases, we still treat them because they do well as far as pain, and we rehab them, but we're not going to be able to bring the tendon back. But in most cases, nothing will. Is it common to need more than 1 treatment? No, it's fairly rare. Every once in a while, we end up putting some more platelets in, PRP, in the future. PRP, how much is PRP? Somebody's asking. PRP runs, I think it's $1,100 to do PRP. Somebody said they need to sign off. They're wondering where they can find a copy of the webinar. If you pull up my name, Stem Cells, on YouTube, it's there. And also, I think we're sending out emails to everybody who signed up for the webinar. I saw you 2 years ago, had x-rays taken. Would I need to come in again for new x-rays, or can we do the procedure based? Call the office and ask Chelsea or Devin at the front to come in and talk to me. Just explain that you had the x-rays 2 years ago, and let me pull them up and take a look. You may not need to. That's to John. Is a low-grade and controlled multiple myeloma patient a candidate for severe arthritis? Yes. I usually end up talking to the oncologist and just getting the go-ahead, the okay from them, because I don't want to step on their toes. But we've done quite a few of those. You can go back to any physical therapist for the procedure. You do not have to go through IRG. You can go to anywhere you want to go. And it says, for the shoulder, is it best for x-rays and MRI to be brought in for? Yes, if you have the films, it's best to bring them in, and then I can take a look at them. If you don't, we can always do the films at the office. Looks like that is all of the questions. Hopefully I've answered everybody's questions. And like I said, I think there's an email going out to everybody that it gives a bunch of information. And you can also access this on YouTube. And a lot of these questions, I think it comes back to set up a consult. And basically, I turn people away. I mean, if I don't think you're going to benefit from the procedure, I don't want to do it. And if I think you need surgery, I can refer you to excellent surgeons. So yeah, that's where the consult is very helpful. Well, thank you, everyone, and I hope everybody has a pleasant rest of the evening.